Good evening. Greetings from Coimbatore. Greetings from my institution, Royal Care Super Specialty Hospital. In the next 15 to 20 minutes, I will be talking about the intensive care management of hemorrhagic stroke in the backdrop of recent 2022 AHA guidelines. Let me start by acknowledging my teachers, Dr. Ram and Dr. Mahendran, who taught me critical care, and Dr. Selvaraj, who taught me anesthesia. Let us get started with the case scenario. This is a 65-year-old gentleman with multiple comorbids presents to the emergency room with left-sided weakness. He is conscious, drowsy. What will be your next appropriate step in terms of management, particularly with regard to imaging? So you will treat the patient assuming that he has ischemic stroke because he does not have any classical signs and symptoms of hemorrhagic stroke, or you will perform a plain CT scan, or you will perform a CT angiogram, or you will go for an MRI. So what are your options? As far as diagnosis of hemorrhagic stroke goes, I think the CT is the best option because of its ease of availability, rapidity with which it can be done. And so it would be the most ideal modality with regard to imaging in hemorrhagic stroke. MRI also could be very helpful, and it's very sensitive in terms of diagnosing hyperacute intracranial hemorrhage. CT angiography, particularly in the first few hours of intracranial hemorrhage, is useful to identify candidates who are at risk of hemorrhagic transformation. As follow-up CT, particularly within the first 24 hours, will be useful in patients with low GCS to identify edema, herniation, or hydrocephalus. There are very good neuroimaging markers in a non-contrast CT, like different densities within the bleed or an irregular margins of the bleed, or good clinical markers like time since onset of bleed or use of anticoagulant, which can predict hematoma expansion. So there are neuroimaging markers and clinical markers which could predict an early hematoma expansion. So these are various neuroimaging signs which you could pick up from the CT. For the want of time, I'm not going into detail. So these neuroimaging markers could be helpful in triaging this patient to decide on the intensity of monitoring and to prognosticate outcomes. So these markers could be used for these purposes. Apart from making an initial diagnosis, you also should look for any macro or microvascular pathogenesis, which always is associated in most of these patients with intracranial hemorrhage. So if your patient has a isolated intraventricular hemorrhage without any parenchymal hemorrhage, so these patients should be subjected to a DSA. And if this is negative, the DSA needs to be repeated in the next 3 to 6 months. In case of spontaneous ICH in patients aged less than 70 years, if they're having a lower ICH, or someone between 45 to 70 years, if they have a deep-seated or a posterior fossa ICH, they need to undergo a CT angiogram, plus or minus venogram if you have a suspicion of venous thrombosis. And if this is negative, they need to be subjected to MRA plus or minus venogram. So if any of this is positive, they need to undergo a DSA. Apart from that, if you're suspecting a non-macrovascular pathogenesis, they need to be undergoing a MRI to look for malignancy, cavernous malformation, or amyloid angiopathy. So apart from vascular pathologies, if you're looking for a non-vascular pathology, they need to have an MR to look for malignancy, cavernous malformation, or amyloid angiopathy. Apart from these are the blood investigations like blood count, renal functions, liver function, blood glucose, coagulation profile, and cardiac enzymes and an ECG. And also you need to look for a toxicology screen, particularly to look for sympathomimetic drugs or cocaine, which could contribute to an intracranial hemorrhage. Let us come back to a patient. This is a CT scan, which shows a capsular ganglionic bleed. So what will be your subsequent management? So the options will be to send the patient for a DSA or for a CT angiogram, to place an ICV monitor, to reduce the blood pressure subsequently, to put them on a prophylactic anti-seizure medications, or to consider or not to consider surgical intervention at this point. So these are the various aspects probably you need to consider, and we will be discussing each of this in detail. One of the most devastating problem or a major catastrophe of an intracranial hemorrhage is a hematoma expansion, which happens very early in patients with intracranial hemorrhage. This is a very old paper which looks at hematoma expansion by doing a CT in the first hour and in the 20 hour. Even when you do a CT in the first hour of intracranial hemorrhage, about 1/4 of the patients shows hematoma expansion, and these hematoma expansion is clinically correlated with the neurological deterioration. I think moving on to the blood pressure management in patients with ICH, this is one of the most debated and most discussed topic, and the various aspects include what is the target to which you should reduce, what drugs to use, how early you reduce. So these are the various aspects which need to be discussed, and let me take you through various papers which address this issue. The INTRACT is one of the landmark paper which looked at blood pressure reductions in patients with intracranial hemorrhage. The target blood pressure was 140 and 140 in two different groups, and there was a trend to lower hematoma growth, and there was no adverse events related to the acute reduction in blood pressure. Unfortunately, there was no difference in clinical outcome in these patient groups, and the paper was not powered enough to look for any clinical endpoints. This is INTRACT 2. Here he had two target groups. One is 140, the other is the control intervention arm. They had 140, and the control they had 180 systolic, and they tried to attain this blood pressure within an hour. And the primary outcome were death or major disability, and the secondary outcome were a reduction on the MRS scale. So they did not see any major difference in the primary endpoint, but the secondary endpoints were significant. But this paper was criticized on various aspects, particularly most of these patients in this study were from China, and they were already on urapidol drug. The other papers which looked at blood pressure management in patients with ICH is one is the ATTACH trial. This is a small study, and this had a 4-tier dose escalation of IV nicardipine for lowering blood pressure. And this paper confirmed the safety and feasibility of blood pressure reduction in patients with ICH. On the contrary, the ATTACH-2 trial, which had close to 1,000 patients, and they compared two arms. One arm they had 120 to 140, and the other arm they had 140 to 180. The IV nicardipine was the only antihypertensive used. They could not make out any major difference in terms of mortality or functional outcome, but however, there were higher adverse renal events. And the problems with all these papers are there are differences in ethnicity, there is difference in terms of treatment duration, and there are difference in terms of the blood pressure, systolic blood pressure target you achieved. So these differences make the comparison between these papers difficult, and the achieved systolic blood pressure, the variability in terms of reduction and the magnitude of reduction had a major bearing on the hematoma expansion, neurological deterioration, functional independence, and mortality. So these are the aspects of the hemodynamics. So the systolic blood pressure you're trying to achieve, how much was the variability, and what is the magnitude of reduction. So this has got a role in reducing the hematoma, and this is also associated with neurological deterioration in long-term functional independence and survival. This is what the recent AHA ICH guideline has to say, and they say that what is important in blood pressure reduction in patients with ICH is a smooth and sustained reduction without a drastic variability. That is what is more important, and that's what is reinforced in these guidelines. And they also are not clearly define the blood pressure targets for patients who are undergoing surgery, and they also emphasize to initiate blood pressure reduction within 2 hours and try to attain your target within an hour. This is associated with reduction in hematoma expansion and better functional outcomes. So whenever you want to do, try to start early and try to attain your targets, but within an hour, which is associated with lesser hematoma expansion and better functional outcome. So the message here is smooth and sustained reduction. Moving on to the next topic, it is anticoagulation ICH. We do come across a lot of these patients in the recent times, and this anticoagulation in patients with ICH is associated with more hematoma growth and higher mortality and morbidity. This needs to be addressed very promptly and aggressively. The options, particularly when they are on oral anti, the options will be fresh frozen plasma or prothrombin complex concentrate. The IV vitamin K could be used in place of peroral, but there is a small risk of anaphylactoid reactions. As far as factor 7 is concerned, they can limit hematoma expansion even in non-coagulative patients, but this comes with the risk of increased thromboembolism, and it is not recommended in an unselected patient. As we all know that recombinant factor 7A does not replace clotting factors, even though the INR normalized, and this should not be used as a only sole agent to reverse INR in patients with intracranial hemorrhage. As far as the antiplatelet drugs goes, the reversal of antiplatelet agents was very extensively studied in patch trial. They found that it was associated with higher mortality and worse neurological outcomes in the group which received platelets, particularly when you have a softer indication for platelet transfusion. Like if there is no severe thrombocytopenia, and if the patient is not going for neurosurgery, in these kind of scenarios, if you're probably trying to transfuse platelets, so they are associated with poorer outcomes. And also the CHAN trial, very probably not very recent one, and this looked at the usage of antiplatelet and with the relation to hematoma size, expansion, and neurological outcomes and mortality. What they found was they did not see any relation between the prior antiplatelet use and the hematoma size or expansion and the neurological outcomes and mortality. So in this paper, they did not find any correlation to these parameters with regard to prior antiplatelet use. And keep it in mind, in soft, when there is no clear-cut indication for platelet transfusion, and probably if you do, probably this is associated with more worser outcomes, and the platelet transfusion could be beneficial at higher ICH volumes, but probably this needs to be evaluated further. As far as tranexamic acid usage in intracranial hemorrhage is concerned, these are two large papers which looked at it. One is the Stockpest is from Australia. They try to transfuse tranexamic acid by looking at the neuroimaging markers, and the other one is STIC2. So both of them could not identify any benefits, both in terms of survival or in terms of hemorrhage expansion. To summarize, with regard to anticoagulation and treatment in patients with intracranial hemorrhage, if they are on anticoagulant and they develop an intracranial hemorrhage, the anticoagulant need to be discontinued. If they are on vitamin K antagonist based on the INR, you need to transfuse prothrombin complex concentrate and IV vitamin K. And if they are on heparin, probably they need to receive protamine. As far as the newer anticoagulants are concerned, whether it is dabigatran or 10A inhibitors, if they come very early, probably they should receive an activated charcoal. And subsequently, if they're on dabigatran and if edasimumab is available, they need to get edasimumab. If not, they should receive PCC and renal replacement therapy. This is dialysable, and they need to undergo the renal replacement therapy. As far as factor 10A inhibitors are concerned, if alpha antinexate is available, they need to be given, or else you need to give 4-factor PCC. This is in summary about the reversal of anticoagulation in patients with intracranial hemorrhage. Moving on to hydrocephalus, we do see a lot of patients with intracranial hemorrhage presenting as a pure intraventricular hemorrhage and hydrocephalus, and this leads to increase in intracranial pressure, and this could lead to early or delayed deterioration of these patients with intracranial hemorrhage. This is a clear IVH trial which looks at clearing intraventricular hemorrhage by administering TPA, and there is no symptomatic bleeding or infection which is feared of when we try to intervene like this. But the 30-day mortality in this group of patients is 17%, and this is a very small trial, and probably this needs to be validated and studied in a larger cohort. As far as the intraventricular hemorrhage management goes, the surgical management, if these patients are spontaneous with IVH and hydrocephalus, they need to undergo an EVD. This is associated with very good mortality reduction and better functional outcomes. As far as if these patients have a low GCS and an ICH volume more than 30 ml, they need to have if they have a thrombolytic along with the EVD, this also have a modest mortality reduction and a better functional outcome. But if you add neuroendoscopy to these patients, it is not associated with any better survival, but they have a functional outcome benefit, and it also reduces the need for permanent shunting. Coming on to the surgical management of intracranial hemorrhage. So this STITCH trial, I'm sure all of you are very familiar. This is a very large trial which looks at surgical evacuation of the hematoma in the first 96 hours with standard medical management. They excluded patients with cerebral or intracranial hemorrhage. And in patients who had bleed about more than 1 centimeter from the cortical surface, deeper bleed, and these patients did not do well compared to medical management. And if these bleeds are about less than 1 centimeter from the cortical surface, they had better outcomes, though it was not statistically significant. Now, surgical population in patients with intracranial hemorrhage is very clearly defined. It is for cerebellar hemorrhage, which is more than 3 centimeter in diameter, or a volume which is more than 15 to 20 ml, and because of this high risk of brainstem compression or hydrocephalus. It is also indicated in a lobar hemorrhage, which is more than 30 ml, and which is located about 1 centimeter from the cortical surface, and in young patients with a large ICH, which is acutely deteriorating. So these are some of the established indications for surgery in patients with intracranial hemorrhage. This is something which is coming up in the recent few years about the minimal invasive surgery for evacuation of ICH. So in patients with ICH volume more than 20 to 30 ml with a GCS score between 5 to 12, the minimally invasive hematoma evacuation using either endoscopic or stereotactic aspiration along with or without thrombolytic is used with better functional outcomes and better survival. So you have a minimal invasive approach either through stereotactic or through endoscopic guided, it is associated with a better survival and better functional outcome. And they also have a better outcome compared to craniectomies. As far as minimal invasive surgery goes, there are some more subsequent papers which are looking into it. This is something which we will look forward to in the near future. This is the ENRICH trial. Coming on to the other aspects of intracranial hemorrhage as far as the anticonvulsant goes, if these patients have a clinical seizure or if they have a seizure activity on the EEG, they need to be put on anticonvulsant. There is no role for prophylactic anticonvulsant. And if these patients with intracranial hemorrhage, if they have low GCS which could not be explained, they need to have a continuous EEG monitoring. As far as the DVT prophylaxis goes, all of these patients need DVT prophylaxis. They need to be put on an intermittent pneumatic compressive device. And in subsequent days, I think these guidelines recommends to start heparin very early based on the severity of the bleed, even from 48 to 72 hours. And there is a very clear-cut recommendation, isolated stockings without other modes of DVT prophylaxis is not helpful, should not be used. And if your patient with intracranial hemorrhage develops a DVT, probably they need to be put on a retrievable IVC filter till you could start anticoagulation. And this anticoagulation you could start in 1 to 2 weeks time based on the severity of the bleed. Coming to temperature management, and these patients hyperthermia should be aggressively managed as this increase to secondary insults, and there is no role for inducing hypothermia as a part of ICP management. Glucose management, both hypo and hyperglycemia should be aggressively treated. And this is one of the scores for prognosticating patients with regard to 30 days case fatality. And there are about 5 parameters: GCS, ICH volume, intraventricular hemorrhage, infraventricular origin of ICH, and age. So these 5 variables are taken, and based on each variable, the scores are allotted, and this is used to prognosticate mainly in terms of 30-day case fatality. There are some things which are done for many years traditionally, and these things are not very helpful. One is a prophylactic anti-seizure medication. Though we all tend to use it, most of the neurologists tend to use it. As per the guideline, this is not very useful. And platelet transfusion outside the setting of an emergency neurosurgery or severe thrombocytopenia, prophylactic corticosteroids, or using of compression stocking as a standalone for prevention of DVT. These are not useful. So most of the things, whatever I have discussed with you today is from these guidelines. This is 2022 stroke guidelines from the American Heart Association. Thank you for your patient hearing, and we'll be happy to take up if there are any questions. Thank you.